Glaucoma Module Premium Edition. Mapping Bruch's membrane opening minimum rim width. New world in glaucoma diagnosis. No financial disclosure. Objective framework of this video theater involves what is Glaucoma Module Premium Edition or GMPE. Pre-Bruch's membrane opening minimum rim width era, that is pre-BMO MRW era, versus Bruch's membrane opening minimum rim width era, that is BMO MRW era. Finally, how to apply the tools in clinical practice is highlighted. Glaucoma Module Premium Edition is an objective method to assess the optic nerve width. It combines the analysis of neuroretinal rim, retinal nerve fiber layer, and ganglion cell layer thickness. It is based on anatomic positioning system technology. APS technology is a navigation system like GPS. First, the foveal centration is marked. Then, the Bruch's membrane opening based disc center is marked. Then, the fovea Bruch's membrane opening axis is plotted, followed by the 24-line scan examining 48 Bruch's membrane opening positions, followed by a circular scan examining the retinal nerve fiber layer thickness. And finally, we have the examination of ganglion cell layer thickness. This video shows the single beam system on the left side. The scan done with a single beam does not compensate for eye movement, whereas on the right side video with the dual beam spectralis, the eye movements are compensated for with the help of reference scan. Thus, with spectralis dual beam live tracking, the same piece of tissue is examined during glaucoma follow-up. Anatomic positioning system technology can pick up glaucomatous progression at the level of 1 to 2 micron difference between two visits with live tracking. 16 circular scans are being done every second, and every circle has to match with the optic nerve width, thus automatically correcting if there is eye movement. Without APS, the patient's superior temporal quadrant of ONH appears normal in normal head position seen on left side and appears thinned if head is tilted as seen on right side. Fovea is below the BMO center on the left and above the BMO center on the right. But with APS technology, fovea BMO axis is plotted, thus compensating for head tilt and cyclotorsion. This is the same example now applied with APS technology. Head tilt or no head tilt, superior temporal quadrant remains same. Impact of fovea BMO axis. Example 1, +6, where fovea is above BMO center. Example 2, -17, where fovea is below the BMO center. If the fovea BMO axis is not plotted and the ONH quadrants are divided, then it is a wrongly interpreted result. Whereas, if there is a positive fovea BMO axis, the ONH template is categorized after a clockwise rotation. For a negative fovea BMO axis, the ONH template is categorized after anti-clockwise rotation for correct interpretation. Pre-BMO MRW era versus BMO MRW era. Let us first see what is Bruch's membrane opening minimum rim width. Previously, the inner edge of the sclera was identified as the disc margin marked by the green line seen while performing ophthalmoscopy. But recently, the OCT termination of Bruch's membrane, known as Bruch's membrane opening, was identified as the true disc margin marked by the red line. Red dotted lines shows the Bruch's membrane opening based disc margin. Green dotted lines shows the clinically assessed disc margin. Rationale for concluding BMO based disc margin as true disc margin is as follows. Blood vessel and axons cannot pass through the Bruch's membrane, making BMO based disc margin the true one. Reorienting the anatomy. Where is the Bruch's membrane situated? Bruch's membrane lies in between retinal pigment epithelium present on top of it and choroid present lying beneath it. Bruch's membrane opening. Imagine the retinal nerve fiber layer projecting into the disc like the water falling into a waterfalls for better understanding of the concept. Let us see a 3D animation of Bruch's membrane opening minimum rim width. The green line first segments the internal limiting membrane. The red line then segments the Bruch's membrane. Red dot implies the Bruch's membrane opening. Bruch's membrane opening minimum rim width is the smallest distance between the internal limiting membrane and Bruch's membrane opening as seen beautifully in this 3-dimensional animation. Bruch's membrane opening minimum rim width challenged the traditional Bruch's membrane opening horizontal rim width. Isn't every decision for something a decision against something else, as revealed in Dark, seen in Netflix? Let us see why minimum rim width was chosen over horizontal rim width. Chow et al. Revealed BMO MRW yielded a higher diagnostic performance than BMO HRW. Also, sensitivity of BMO MRW was consistently higher than BMO HRW. A study done on glaucomatous neuroretinal rim tissue revealed that the mean deviation of the visual fields correlated better with BMO MRW than with BMO HRW. Also, RNFL thickness correlated better with BMO MRW than with BMO HRW. Let us see an example of a normal disc in real-time scenario. A normal disc will have a normal BMO MRW depicted by the green arrow illustrating BMO MRW. Glaucoma module premium edition parameters of the same eye such as BMO area, BMO rim analysis, RNFL analysis, RNFL thickness and ganglion cell layer thickness all appear to be normal. BMO MRW follows the ISNT rule. Inferior and superior rim width appears to be thicker than the nasal and temporal rim width. Let us see a glaucomatous disc with inferior temporal notch. The inferior temporal BMO MRW is constricted and depicted by the red arrow. BMO rim analysis and RNFL analysis shows thinning in the inferior temporal quadrant. Segmentation scans also reveals an inferior RNFL defect with corresponding inferior ganglion cell layer defect. A study on BMO MRW characteristics was done involving 160 patients, 40 normals versus 40 suspects versus 40 POAG versus 40 PACG were age matched and studied. BMO MRW was highest in the normal group. BMO MRW of suspects were lesser than normal and lowest in the POAG and PACG group. How about the influence of BMO area on BMO MRW and RNFL? BMO area related to BMO MRW but did not relate to RNFL. Hence, among the 160 study population, two groups were divided based on BMO area. Small BMO area group had BMO area of less than 1.8 mm square. Large BMO area group had BMO area greater than 1.8 mm square. All were still age matched and compared. It is easy to appreciate BMO MRW was higher in the smaller group of normals, suspects and glaucomas rather than the larger group, whereas the RNFL thickness was similar in both the groups of normals, suspects and glaucomas. Imagine a large disc and a small disc having same neuroretinal rim area. Large disc will have small BMO MRW and small disc will have large BMO MRW. The disc size does influence the BMO MRW. It was also concluded after ROC analysis that small discs had better diagnostic precision with BMO MRW and large discs had better diagnostic precision with RNFL. Optic nerve anatomy is very variable from patient to patient. Thus, it is important to keep in mind that the optic disc size, that is BMO area, influences the diagnostic precision of BMO MRW. If BMO area increases, diagnostic precision of BMO MRW decreases. Review of literature and other studies also supported this result. GMPE is a promising glaucoma toolkit which helps in serving the glaucoma patient better. Thank you.